My presentation today will be about the updates of chimeric antigen receptors up to the last Society of Hematology Oncology or Hematological Oncology. I know the topic is a little bit tough, but a lot of changes have happened over the last couple of years. The principle is, we know that the T cell kill any infected cell when they have a surface receptor abnormality. Now we need to harness these T cell to kill the malignant cell, not the infected cell. And more, we need to orchestrate these T cell to kill the malignant B cell. So we need to do many tasks, and we need to be successful in that. The story started since 1950, when we identify the cell transfer for turn of immunity like HLA and production of interferon. But the real awareness of making something chimeric or manipulated or genetically manipulated was late in the 80s, where they discover the T cell receptors, and generation of chimeric T cell receptors have been achieved by 1987 to 1989. By 1993, this was the year where we have generated the first chimeric antigen receptor. With the new millennium, this research have expanded and bloomed massively, and we start to focus on CD20 and CD19 as a target. By 2015, we have had the first, the second, and third generation of chimeric antigen receptor. The difference was not in the extracellular or transmembrane domain, but it was in the intracellular domain. We were in the first generation simply having co-stimulatory molecule and stimulation of T cell. But with advancement of generations, we start to change the co-stimulatory molecule or to add something to potentiate the action of chimeric antigen receptor. By 2021, we are now having a fourth generation of chimeric antigen receptors, and we are having a fifth generation of chimeric antigen receptors. The difference is in, again, the intracellular component. And in the fourth generation, they have added a gene to be encoded to facilitate libration of cytokines, enhancing apoptotic process of the malignant cells. And by the fifth generation, not only the cytokine drive have been added, but another drive have been added to go through JAK-STAT3 pathway to augment the apoptotic liability of malignant cells. What is present in the medical approval up till now is from the first to third generation. I think with the study of the fourth and fifth generations, we will have a lot of advancement. This is very weird. These are the processes of making of CAR T cell. What is present in the clinic up till now is the autologous CAR T cell, a T lymphocytes which have been taken from the patient himself. We make leukapheresis, we take some T cells, they are manufactured by viral vector and modification of the receptors. Expansion of CAR cells are made ex vivo, then this is infused inside the patient and the activity starts. The mechanism of action of CAR T cell is by identification of the tumor-associated antigen, which is present on the wall of the malignant cell. And once the CAR-T identified this antigen, they start to stick to this malignant cell, secretion of perforin and many enzymes which facilitate penetration of the malignant cell through the tumor necrosis factor receptor, and destruction of malignant cell is done. And this will liberate a lot of cytokines which will activate the natural T cell subtypes in the host as well. Advantage of CAR-T on stem cell transplantation, that it is infused at a single point of time. It is not an HLA dependent. It targets many antigens, including proteins, polysaccharides, and even glycoproteins. It activates both T4 and T8, and each of them will manifest, will augment the killing power of the immune system of malignant cells. Rapid generation of tumor-specific T cell, capable of rapid proliferation, and they persist for months, not to mention years, and they have minimal graft versus host disease. Who is eligible for CAR-T cell? Not every person is eligible for that. We have specific indications. We have the kinetic of disease. We have the intermediate prior therapy. Some prior therapies might interfere with the CAR-T activity. We have some active infection which prohibited us from giving CAR-T, and comorbidity as well could be a very important denying a patient to be treated with CAR-T. The first step done is apheresis. As I said, 5 days prior to CAR-T infusion, the patient gets into lymphodepletion. The patient stays in hospital for at least 10 days, during which we treat any complication which are very common, especially cytokine release syndrome. And the patient, after release from hospital, should be close to hospital for at least 30 days for delayed complication. And these are the commonest CAR-Ts which are used in clinical trials: the Axi-Captogen, the Tisa-Gen, and the Lyso-Captogen. And each one is written below the indication of therapy. What are, till today, the FDA-approved chimeric antigen receptors for different diseases? We have the Axi for diffuse large B-cell lymphoma and some low-grade lymphoma, and adult with relapsed refractory follicular lymphoma particularly. We have Broxi-Captogen for adult with relapsed refractory mantle cell lymphoma. We have another CAR-T for lymphoid malignancy. We have Tisa particularly for acute lymphoblastic leukemia in childhood age and in some diffuse large B-cell lymphoma. And we have the ETA Captogen for multiple myeloma. Let us start with lymphoma. This is the different CAR-T cells used in lymphoma. The Axi is having co-stimulatory molecule CD28, and it is primed by flow-cy treatment for lymphocytic depletion. In Tisa, bendamustine could be used instead of flow-cy, while in Lyso and Broxi-Captogen, the same flow-cy preparation. And as you see, the Broxi is specific for mantle cell lymphoma. I know it's difficult, but look at the overall response in those patients in different important studies, particularly ZUMA-1, which approved FDA approval for CAR-T cell. We are having overall response in 82%. We are having complete remission in more than half of the patients who received more than 4 or 5 prior therapeutic treatment. And this is the overall graph and progression-free survival for the ZUMA-1, Juliet, and Transcend non-Hodgkin lymphoma study with CAR-T cell. ZUMA-5, we have studies from ZUMA-1 to ZUMA-12 in a different population and different protocols with CAR-T. ZUMA-5, we are using axicabtagene for relapsed refractory low-grade lymphoma, namely follicular and marginal zone lymphoma. And you can see that there is marked improvement in overall survival in those patients who have been refractory to everything, particularly in marginal zone lymphoma, but the progression-free survival is more holding in the follicular lymphoma. Concerning mantle cell lymphoma, we can achieve complete remission in 67%, more than 2/3 of patients with relapsed refractory mantle cell lymphoma, with progression-free survival up to 50% over 3 years, which is a real achievement. In CLL and SLL, the situation is the same. We can have even minimal residual disease negativity in 75% blood and 65% bone marrow. And by next generation sequencing, this minimal residual disease negativity could increase to 87.5% in the peripheral blood and up to 3/4 in the bone marrow. These are some ongoing studies, and you can see plenty of cocktails are there, like for lymphoma and CLL and for acute lymphoblastic leukemia. One of the very stubborn diseases for treatment is the CNS lymphoma, whether primary CNS lymphoma or secondary CNS lymphoma. In a very nice paper published on September, maybe 1.5 or 1 month ago, showing the evolution of therapy of CNS lymphoma, and by 2020, we start to have documented response with CAR-T therapy of either primary or secondary CNS lymphoma, which is again a very good new achievement in this field, especially after the reports of ibrutinib and of IMiD therapy. Multiple myeloma is characterized by presence of B-cell maturation antigen, which have been exploited to engineer CAR-T for multiple myeloma. This is the approved CAR-T for multiple myeloma, which is idacaptagene, and it has been approved in the last March, and this drug is approved for people who took before 4 lines of therapy and failed, including proteasome inhibitors, IMiDs, and even anti-CD38 antibodies. And these are the results. At 12 months, we have overall survival 78%. At 24 months, we are having more than half of the patients still alive, in spite of being refractory to everything before. When we speak about efficacy in KARMA study, we are having overall response with IDA 81%, while with the new monoclonal antibodies, the CETA, the response is up to almost 98%. But this is on the expense of complications, and as you can see, particularly neurotoxicity subtypes is more frequent with the CETA. This is the CETA captagene. The most important thing in the CETA captagene that each receptor is having 2 different epitopes simultaneously to be attached to a couple of malignant cells, not only to one malignant cell. And these are the trials in multiple myeloma with CAR-T cell. The KARMAs are all with IDA captagene. The CARTITUDE are with CETA captagene. And we shouldn't forget the strong coming BB2121. More receptors are there to study in plasma cell. What about the future of CAR-T cell in multiple myeloma? We might have very soon, not autologous, but allogenic CAR-T T-cell from on shelf, not from the patient, tandem bispecific dual target, and alternative target. Acute lymphoblastic leukemia, this is the study which made approval, ELENA study, and you can see that the overall remission rate is 81%, minimal residual disease in 100% of cases, and this was upgraded later on by another study. This is a very living example of success of CAR T cell. In 2010, Emily Whithead was a very relapsed refractory case of acute lymphoblastic leukemia, and she was one of the very early phase 1 cases for CAR T cell therapy. This is herself again after a couple of years, after 7 years, and after 8 years of CAR therapy, when she was totally resistant to any line of therapy, and she is practicing everything in her life. This is another child for after 6 years of CAR T therapy for acute lymphoblastic leukemia. Moreover, she's now having a foundation to raise funds and to support children with acute lymphoblastic leukemia for CAR T therapy. These are the updates in ALL CAR T therapy. We have complete remission rate of 85.5%. We have minimal residual negativity in 99.1%. With such success in children, a ZUMA-3 study, which tries CAR T cell in adult acute lymphoblastic leukemia, showed a success rate to achieve remission in 70.9%. But we have another category, which is bone marrow-free biopsy plus free bone marrow in 7.3 as well. حاجة الملحوظة جدا, or what we noticed lately, is we are having new terminology for the response in acute leukemia, in acute lymphoblastic and in acute myeloblastic. So we need to know all of them, because over the last 18 months, a lot of nomenclature have been introduced. Nothing is that innocent as we see. I think manipulation of the immune system is like a wolf in a sheep's clothing. Some beautiful success, but we do have significant and increased toxicity by these biologically manipulating things. The most important acute CAR T complication is cytokine release syndrome and ICANN, which is immune effector cell-associated neurotoxicity. And as you see, the CRS is occurring in the range of from 77 or even 42% up to 91% of cases, with a different grade from grade 0 to grade 1. And we need to do supportive care for all of them, but anti-IL-6 is a treatment of choice, steroids, and anti-IL-1 and vasopressor. The delayed CAR T toxicity is due to prolonged cytopenias or B-cell aplasia and hypogammaglobulinemia. So we have the autologous CAR T, we have the allogeneic CAR T, and over the last 1.5 years, we are having natural killer CAR cell to treat malignancy. And this is a wonderful paper published from Germany and from the United States as well about the immunotherapy with natural killer CAR cells. And as you see, this is the CAR natural killer. We are having only 3 studies in the United States, and we are having 14 studies from China, and we are having 1 study in Germany. This has been published in June 2021. And this might dictate for us to readjust our campus, not to look always to the West. We might have a real respectable science from the East as well. So let us revise the trials overall. Look, the 3 above trials are in the United States for natural killer manipulation. And most of them are in hematology field, and some of them in China are having dual target. They are not targeting CD19 only. They are targeting CD19 and CD22 as well. And for the CAR T specifically, most of them are from China, one of them from Germany, and we are having the lion's share in hematological malignancies, and a new target which have been documented for the first time, which is CD7, which is a new miraculous treatment for cases of T-cell malignancies and some cases of AML with CD7 expression. So these are the up-to-date, which have been again published in JAMA Network in last July about the percentage and number of CAR-T trials. You can see that China has 55% of cases of hematological trials, and in spite of that, the number is in favor of the United States of the enrollment of cases. But again, we are having a force. We are having now autologous, allogenic CAR-T, natural killer CAR-T, and we have the new category which is known as universal CAR-T. And as I said, the number enrollment is more in the United States. So this is how cancer immunotherapy is progressing over the last 3 years. And the CAR-T is on top of progression, and CD19 and BCMA are on top of list. The fifth type of CAR-T is the academic CAR-T, which is produced in academy, not on industry. And as you see, this is 22, this is 21. We are having progression in China, 60% in industry, while 40% of cases or studies are academic CAR-T. This abstract have very much actually captured my attention in the last ASH 2020, where a novel, something on chimerism, have been produced in China, which has been called the STAR, which is a systematic or synthetic T-cell receptor and antigen receptor CAR-T manipulation and use in acute lymphoblastic leukemia. The principle is brilliant. They are joining the T-cell receptor and the typical CAR-T receptor together to form the STAR receptor to kill the malignant cell. So I'm having a more powerful demolition power to kill the malignant cells via the T-cell receptor manipulation and via the CAR cell. And the Earth is moving very fast nowadays. We do not have only first generation of these stars, we have second generation which have been introduced to clinical trials from the start of this year. Let us see the first generation results. We are having, this is the demography of the cases, and this is the response. This is the active disease, and within 14 days, all the 18 cases which have been enrolled in this study have went not only to CR, but also to minimal residual disease negativity with CR. And some of them bridged to the green or olive color, which is the stem cell transplantation. One patient relapsed, another patient relapsed, which re-induced by chemotherapy and went to stem cell transplantation. So we are having a very short performed or manufactured combination of T-cell manipulation, T-cell receptor manipulation, and CAR-T with a good result. And this was as well associated with markedly decreased number and severity of cytokine release syndrome and neurotoxicity. And the investigator concluded that the SMART or the STAR T-cell compared to conventional CAR-T could be a very good technical feasibility, clinical safety, and efficacy in treating CD19 positive lymphocytic malignancies. A high CR rate could be achieved by day 14, and long-term observation and more studies are required. The second Chinese achievement, which have been again presented 1 month ago in the Society of Hematological Malignancy, is a fast CAR T cell. The autologous T cell, to produce a CAR T cell, usually in the fastest hands, it will take a couple of weeks up to 1 month. But they could do that in 3 days in China by specific manipulative and industrial or academic production, which make life very easy for the patient, because many of those relapsed and refractory patients can go in this month into irreversible condition or even lose their life before their CAR T cell to be available. So in the last months, I have been enlightened that China is doing something different by the STAR and by the fast CAR T cell production. The last thing which have been again presented by 2 studies is a new target of CD7. So we have new targets. Let us look at the hematology. All of them we know, most of us know these targets, including the complement in multiple myeloma. But what was really interesting to me, and again this paper is published in September 2021, is CAR T for chronic myeloid leukemia. And in spite of all achievements we have had in chronic myeloid leukemia, they are trying to produce CAR T for chronic resistant cases of chronic myeloid leukemia. And what was they trying to approach in such case is CD26, which is very specific in such cases. In these trials, many solid tumors have been enrolled, and success in some of them very much even exceeding hematological disorders have been noticed. But what was really, again, interesting for me is the imaging of CAR T cell. And for that, they have invented a technique which is called ICOS, which is a very advanced PET-CT technique which can trace the CAR T cell, where they are, and how much they eradicate the disease. A couple of papers have been published, as I said, this year, and they concluded that the potential of ICOS immuno-PET imaging for monitoring of CAR T cell therapy, distribution, and outcome. The future research concerning CAR T cell could be that identifying new target. We can have BCM plus epithelial growth factor receptor. Reduce the immune responsiveness and complication. We can add something like checkpoint inhibitors. More sensitizing of the T cell and enhance persistence and response. Something like ibrutinib could be added. Early administration of tislelizumab to decrease cytokine release response. Investigate new technologies, as I said, natural killer and neutral CAR T cells. And lastly, we can explore allogenic off-the-shelf technology, not too dependent on long-time preparation from a self T cell. The situation in the literature a couple of hours ago that we are having 4,902 abstract on CAR T cell, most of them after the year 2015. So curing malignancies, particularly hematology, and even some benign disorders by CAR is the dream becoming reality. As I used to say, CAR T cells are a living drug and a possible option where none have existed before. And in spite of the financial toxicity and in spite of the technical difficulty, we have to have the power, the knowledge, and we have to have our own plan to have hands-on experience in that. But we have to keep an eye on the cost effectiveness of using CAR T in different diseases. With that, I finish my presentation. Thank you very much.